Hi, welcome to USMLE STEP Prep for Dummies, which is your one-stop solution for all Step 2 related material. Today's module is genetic screening, which is an important OBGY topic. So the first thing that you need to remember is that genetic screening is offered if the mother is willing to go for confirmatory testing once you do the genetic screening, and then if the confirmatory test turns positive, she's willing to go for termination. So the first group of conditions we need to discuss are aneuploidies. So risk for these aneuploidies increases as maternal age increases. And there are three main aneuploidies that we need to consider. You have Downs, which is trisomy 21, which is pretty easy to remember. You have Edwards, which is trisomy 18, and Patau, which is trisomy 13. So a trick that I used to remember for remembering that Edwards was 18 and not 13 was that it looks awfully similar to 3. So E is not 13 or E is not 3, which is how I remember that Edward actually stood for 8, E stood for 18 and not actually for 3. It's a little confusing, but this is how I used to remember it. So when do we do an asymptomatic screen? If the lady has an increased maternal age or if she has a previous pregnancy with aneuploidy. And for diagnosis, we do a screening tool, which is non-invasive, and a confirmatory test, which is invasive, and the treatment is termination. So if the mom wants a screen, so we do a screening test and we put her in categories. So if it's positive, the screening test is positive, she's a high-risk lady, so we do an invasive confirmatory test. And if the risk is negative, and if the screening test is negative, she's low risk, which is why we don't do anything else. And the confirmatory test, if it's positive, then it means it's a genetic disease and we usually terminate the pregnancy. So first trimester screening, as you can see here, has a good detection rate and a low false positive rate, which is why it's the best overall. And the important first trimester screening tests are USG for nuchal translucency. So normally it's less than 3 centimeter. And you also have PAPPA, which is pregnancy associated plasma protein A, and you also have HCG. Next, second trimester screening. So you have either the triple screen or the quadruple screen. The triple screen is HCG, alpha fetoprotein, and estriol. Now, the most important thing in this is alpha fetoprotein. Alpha fetoprotein is increased when you say that the level is more than 2.5 multiples of median. And the most common cause of increased alpha fetoprotein is not any disease but incorrect estimation of gestational age. Other causes include spina bifida, anencephaly, fetal congenital hydronephrosis, benign obstructive uropathy, etc. And if you get an abnormal alpha fetoprotein and you're suspecting a neural tube defect, you do an obstetric ultrasound. Now, a quadruple screen is where you have your triple screen plus inhibiting. Now, why do we do all these tests? So that we can fill all these tables, correlate them clinically. So in trisomy 21, now I used to remember the Downs babies are bi. So beta HCG and inhibin is increased in Downs babies and everything else is decreased. So alpha fetoprotein is decreased, estriol is decreased. For trisomy 18, which is Edwards, everything is decreased and inhibin is normal. And for neural tube defects, alpha fetoprotein is increased while everything else is normal. So this table is pretty useful that way. Now, maternal serum alpha fetoprotein testing, it's decreased in aneuploidies, that is trisomy 18 and 21, as you can see here, and it's increased in neural tube defects like anencephaly, spina bifida, or if your abdomen wall is open, like omphalocele gastroschisis, and also in multiple gestation. So there are different types of neural tube defects, and the risk factors are low folic acid intake, methotrexate, anti-epileptics, diabetes, prior pregnancy with neural tube defects. The screening that you do is a second trimester ultrasound or maternal serum alpha fetoprotein, which is increased, and you treat them with folic acid. Now you can also do a combined screen, which is a first trimester screen and a second trimester screen, or a sequential screen where you do first trimester and then you do a second trimester. Then one more test that you can do is a cell-free fetal DNA test. So this is actually a non-invasive test because you're going to get the fetal DNA in the maternal blood, but it's not always 100% accurate because you still follow it up with an invasive test if it turns out to be positive. The main indication for cell-free fetal DNA is if the mother is 35 years or older, right? So the indications are if the maternal age is more than 35 years old, or other features of aneuploidy like abnormal maternal serum screening test, or fetal aneuploidy, previous pregnancy with aneuploidy, or some translocation is there. And you do it for fetal sex determination or screening of all these trisomies and all aneuploidies. Now, there are certain conditions where you do genetic testing, for example, in white European males or people we do cystic fibrosis, and for African American people we do sickle cell disease genetic testing. So this is a table that summarizes everything. So the first trimester combined test is for screening. It's not diagnostic. Cell-free fetal DNA, again for aneuploidy, it is a high sensitivity and specificity, but it's not diagnostic. Chorionic villus sampling is invasive, so there's a risk of abortion, and it gives you a definitive karyotypic diagnosis. Second trimester quadruple screening includes beta-HCG, estriol, alpha-fetoprotein, and also inhibin A. And this is again to screen non-diagnostic. Amniocentesis is invasive, and second trimester ultrasound is used for measuring fetal growth and also fetal anatomy, and also confirms the placental position. So that's it.